Welcome everybody to Rush Nephrology Renal Biopsy Conference for 9/21/23. We're going to leave this picture up for a second. Go back, Vera, to the reunion picture. Yeah, so I just want to brag about something. We had a fellow reunion a week ago on Sunday, and invited every fellow that we've ever had graduate from our program. Went back 50 years. With Dr. Armbruster graduating in 1973. We had at the Shed Aquarium, we had 70 fellows show up from over 50 years, and as far two from Hawaii. It was a great event. It was a very special night, and we're just very proud of our program and very proud of everybody that came. And it was just a very special night. You can see Ed Lewis there on the right. Barely see the rest of us, but everybody's beaming because it was a wonderful night and a great event, and we had good weather, and it showcased our program, it showcased Chicago, and it showcased the aquarium. So moving on to the real meeting. This is Renal Biopsy Conference. We do have an activity code today. This conference is being recorded, and if you're not on our on our email list, let us know. We are also have a YouTube channel that you can look at all the old conferences if you choose. We've got a great case today, Dr. Whittier. Hopefully I'll have some interesting discussion. I think it will. I think this is a evolving topic. To ensure patient privacy is preserved, we basically change everything. Although in this case, I believe, Bill will tell you that he got permission to use everything. So in fact, I think it is the exact patient information today, but generally we do keep it the same. And we have nothing to disclose as usual. So with that, I think, Bill, are you going to read us the protocol?
Yeah, the patient is a 23-year-old nurse at the hospital, and she gave her permission to use her exact values. So she's really doesn't have that much of a medical history except for Raynaud's. She's a young woman. She's not on any medicines, and she presented to the hospital with severe bloody diarrhea. So 5 days before admission, she had noticed some abdominal pain. She had had watery brown diarrhea at first, and it turned to bloody 1 day prior to admission, which is kind of what freaked her out and said, boy, I better get to the emergency room. No medications, no supplements. Prior to the diarrhea, her meals were a chicken salad sandwich from the hospital and a fried chicken sandwich at a fast food restaurant. In the emergency room, when she got there, she was not orthostatic. She had completely normal renal function. She was admitted to the general medical floor, and she was given pain control with Toradol. She was given hydration, azithromycin, supportive care. They did a CT abdomen and pelvis with IV and oral contrast, and it showed bowel wall thickening of the entire colon and reactive lymphadenopathy. GI commented that they thought that was consistent with an infectious enteritis. Her stool culture, her C. diff toxin, and her stool O&P were negative. She continued to have 6 to 10 bowel movements per day in the hospital, but they actually transitioned away from being bloody to now non-bloody. On day 2 of her hospitalization, though, she became oliguric. Day 3, she was completely anuric. And with that, of course, she had a precipitous rise in her serum creatinine, and she was ultimately started on dialysis a couple days, or maybe within 5 to 7 days of her hospitalization. So her past medical history is really nothing except for Raynaud's. She's a young, healthy woman, no medications, no herbal supplements, no previous surgeries, no family history of any renal disease, autoimmune disease, anything really. Her family's healthy. She has a boyfriend. She is not married. She does not have children. She's not had miscarriages. Social history is also unremarkable. On exam, it was really pretty normal. I mean, she was quite anxious and she was pale, but other than that, she didn't have any edema. Her lungs were clear. She didn't have a rash. Her arthritis or her exam for the joints was normal. Her labs on admission actually looked pretty darn good in the emergency room. So her white count was 13.8, which was elevated. Her hemoglobin was 15.5 and platelets were 174. She had a normal diff. Her creatinine was 0.73. She actually had labs about a year ago where she was also was 0.73. Her albumin was 4.1 and her total bilirubin was 1.1. Her urinalysis was concentrated with an elevated specific gravity. Her pH was 6.0, trace protein, positive ketones. She had 2+ blood and 7 to 10 red cells. but she was also having bloody diarrhea, and we're not sure if it was completely a clean catch. By day 3, though, when she had renal failure, her hemoglobin had dropped down to 11.8 and her platelets were 77. The peripheral smear showed few schistocytes. Her tick count was barely elevated at 1.8%. Her haptoglobin was normal at 43. Her iron studies were normal. She did have an elevated ferritin at 2892. Her electrolytes are there, which were significant for a bicarb of 17. Her creatinine was 2.6, and this was on day 3. By day 6, it was up to 10. Her total protein was 4.3 with an albumin of 2.2 compared to the albumin of 4.1 on admission. Her total bilirubin was 2.5. Most of it was indirect. Her alk phos was 50. AST, ALT, AST and ALT were normal. LDH was about doubled at 480. Her autoimmune serology that we had available was negative, including ANA double-stranded DNA and PR3 and MPO antibodies. Her complements were normal, and her hepatitis serology was normal. HIV is not, oh, there it is. Yeah, HIV was also negative. Her ADAM-TS13 was pending. Her stool culture, her C. diff toxin PCR, her Campylobacter antigen, her stool and ova parasites was negative. There's a Shiga toxin that's a send out to Mayo Clinic that was pending. And her renal ultrasound showed increased echogenicity. She had loss of the corticomedullary differentiation, and her kidney sizes were normal.
Any questions for Dr. Whittier?
Bill, was anybody else sickened by the chicken salad, or have you had occurred? Did any other events occur in the hospital personnel?
No, not at all. And
single isolated event.
That's right.
Thank you.
We have a LDH. I think it was
about 480, and the upper limit of normal was 240.
Did hemoglobin drop?
Yeah, it went from 15 on admission down to 11.8 on day 3, and her platelets were 174 on admission, and by day 3 were 77.
Okay.
Day 3, she was already completely anuric.
That's that's a big point. Thank you. Whoa. Okay, we have a poll. Before we discuss it, we don't really have anything else, and you know, we've got this patient who's pretty sick, and you have to make a decision right now. So, what would you do, pending any more information? Would you do a kidney biopsy? Would you do no biopsy and supportive care? No biopsy and stop antibiotics? No biopsy, start steroids and plasmapheresis? Or no biopsy and start eculizumab? If you really think I would do a biopsy and treat, you could put that as number 1. We just didn't want too many options. But if you think a biopsy is important and you do that, then that's number 1, no matter what else you're going to add to it. So,
sorry, for some reason it came up as 2 questions. Ignore the second question on the poll, but just
and you can put things in the chat too.
Yeah.
remember, we don't know who's voting. Nobody's going to get called out.
results are shared.
So the majority by far says kidney biopsy, which is really interesting. We'll talk about that in the discussion, whether we need a biopsy or should we just have some sort of empiric treatment or just supportive care, which are the 2 through 5. But 58% say kidney biopsy. They really want to see what's going on. So that's great. Let's discuss it. Dr. Corbett, you want to tell us what your thoughts are on this case? Would you do a biopsy or would you treat this patient? And if so, empirically, with what?
No, I would do a biopsy. I want to know what I'm dealing with. I know everybody probably has an idea. I mean, I've got a number one high on my list, but you could be wrong. And in this situation, I think the biopsy, for me at least, would be very helpful. I mean, what's kind of screaming out here is HUS, right? I mean, we figure sugar toxins pending. The common one's what, 015787. I know in Germany there was a different one. I haven't memorized that name, but or the number for that. But I mean, just with the bloody diarrhea and the acute renal failure and schistocytes and thrombocytopenia and anemia evolving. I mean, her haptoglobins are still in the relatively normal range, but they may well be on the way down and the LDH is up. I mean, for me, it just screams thrombotic microangiopathy from HUS, but colon as well as the kidney. I guess that's possible. Ulcerative colitis, inflammatory bowel diseases. She hasn't really had a history of it. She's had Renal's disease, but I guess, ulcerative colitis and inflammatory bowel disease be associated with IgA nephropathy. She could have a crescentic IgA. Otherwise, I mean, those are the ones that stand out to me. I'm sure others have possibly more extensive differential, but the HUS with the bloody diarrhea, and obviously not atypical HUS because she's got bloody diarrhea, is the one that for me is like the top three. Every time I do that, I'm wrong. So we'll see what the biopsy shows.
Top three. It may be the top three, but you'd think if you were that sure about it was the top three, you would think that you wouldn't necessarily do a biopsy. So I want someone to make the case, either Dr. Glassick or Dr. Reen. Would you do a biopsy, Dick?
Yeah, I don't think I would have in this case with a platelet count of 77,000 and all of the clinical features supporting a typical HUS, hyperbilirubinemia, everything. But the one hooker here for me is Raynaud's. And I was thinking an antiphospholipid antibody, which of course would be critical in determining how to treat the patient, since if this is typical Shigella-related, enterotoxin-related HUS, the treatment is supported. Whereas if it is an autoimmune phenomenon, treatment may be needed, and that lab test probably will help a bit. I do want to comment on the haptoglobin. Whenever you see this much inflammation with a ferritin of over 2,000, the haptoglobin level starting might have been 200. Haptoglobin is an acute phase reactant, so you have to interpret the haptoglobin in light of what it might have been before the onset of the HUS. And I think this would corroborate the diagnosis of a severe renal limited thrombocyte TMA. I don't see that the biopsy is going to contribute a lot to management.
I was thinking as AHUS, and I do think she has underlying kidney disease to start with. She has echogenic kidney, so she must have some sort of a previous, that indicates to me some sort of chronic process going on. And I will also actually suggest to repeat the peripheral smear because it's a waxing and waning phenomena. So we will see more fragmentation than we saw initially. I would have actually treated this patient with the eculizumab, even knowing that Shigella may come back positive, and there are some literature that they can use eculizumab in those patients. That's what I would do.
So you would pick number 5, no biopsy, start eculizumab, or
That's
biopsy?
right. That's right.
You're that confident. You're and I'm not criticizing or even questioning. You're that confident of what she has, and you feel comfortable with using eculizumab.
Yeah. There is a back of my mind is Raynaud's phenomena. I hope I'm not dealing TMA related to that phenomena, but I still wouldn't go wrong using eculizumab.
I love how Roger says he's not questioning you, but he does question you by saying you're sure, right?
I know.
I love it.
Hey, Roger.
Yes, absolutely, Mario.
So I would do a biopsy. I agree with Steve. I mean, I don't know why we continue to dance around and not address the issue head on. I don't think a platelet count of 77,000 is a contraindication to a biopsy. I mean, I have biopsy patients with that kind of platelet count all the time without issue. Bill Whittier can comment on that. He is the expert on biopsy. But I just think it's the wrong message that a platelet count of 77,000 is a contraindication to a biopsy.
Yeah, I mean, Dick can comment, but I don't know that that was a tiebreaker. I think, Dick, you just feel pretty comfortable this is HUS, this is a diarrhea, you know, infection-related HUS. Is that right?
Yes, I mean, I'm not saying the biopsy is contraindicated, but relative to its clinical value in deciding how to manage the patient, I would have to say that it's not high enough to take the small risk.
Dick, do you think?
I know the platelet count is 77,000. What was it the moment you put the needle in the patient's back is the important issue. And if it's 50,000, and we don't know what the function of those platelets are, after all, she's increasingly azotemic from acute renal failure. Those platelets are not going to work very well anyway. So I would be a little wary about putting a needle in this person's back. But
one of the things, we still do a bleeding time. So I know there's a lot of controversy about that, but at least in our experience, we've found that it's helpful. There's no question there's plenty of data out there that shows you as the platelet count drops, especially when it gets under 100,000, that there is the potential for an increased risk of a biopsy, but, it's not an absolute. And, with a platelet count of 77,000, and if that's what it is when they stick the needle in and her bleeding time's normal, I think the risk would be relatively lower. But you're still going to have to pay close attention to it. There's no question about it.
Dick, if the platelet count were normal, would you feel differently? Dr. Glassick, if the
I'm
platelet
sorry, I
count,
didn't hear you.
if the platelet count were normal, would you feel differently? Or you're just really comfortable that's what
well,
you
I'd be a
have?
little bit more, I'd be a little bit more inclined to do one, although I must say this clinical syndrome is so compelling. Bloody diarrhea, hemolytic anemia, and hematuria and anuria. I suppose you could say, well, does she have total renal necrosis? Bilateral, and that we should do a biopsy to discover that. That's not going to lead you to any different treatment. It's just going to mean the prognosis is grim for recovery. And I think there's other ways to find renal cortical necrosis other than the biopsy. Specifically, a nice CT of the kidney, perhaps with a little contrast, would give you the answer.
I know Roger made me nervous from the get-go when he basically said, there's a really controversial topic and there's a lot to be learned from it. I was like, I have a feeling, it's what we think it is so far off the reservation, it's not even funny.
Yeah, this is a biopsy conference.
Of course, it is a biopsy conference, and of course we did a biopsy, but that doesn't mean that the question still doesn't come up. And Bill will address that at some point. The decision to or to not do it, and the only other question, I mean, obviously it is controversial because we spent the last 15 minutes even talking about whether a biopsy should be done. And that's really what I'm kind of getting at. So the only other thing I want to ask Dr. Glassick, he said, yeah, the treatment is conservative treatment. So are you that comfortable, Dr. Glassick, that you would not biopsy this patient and not treat? You would just follow this patient and treat supportively?
Well, if she's anuric and has hemolytic uremic syndrome, she may have renal cortical necrosis bilateral, for which there is no treatment. Yes, I would like to know if that's happened because, then I can dispense with eculizumab and plasma exchange and steroids. I am personally worried about the history of Raynaud's. And I would really like to know if she has a potential autoimmune disease. But I don't think the biopsy is a non-specific finding. It's just going to show TMA. Where is it going to be? How is it going to differentiate a disease that is going to be treated in some unique fashion.
Mm-hmm.
Now, Steve mentioned crescentic glomerulonephritis. Yes, of course, it's possible, but this would be a highly unusual presentation.
Well, I was
And
just saying vasculitis, because I've seen
Vasculitis.
vasculitis involve the colon as well as
Yes.
obviously the kidney.
Yeah.
And the Raynaud's makes me always think about scleroderma or scleroderma renal crisis. But I just point out her blood pressures. I know you can be normotensive, but that doesn't even seem like 116/80 would apply to that. But I think that we should take a look at the biopsy at this point, and we'll see what the wheel says. Who the wheel picks.
And I'm not sure if Dr. Dillon, our fellow, or Dr. Patel want to say anything, but I think on rounds for about 2 days, I was having this exact same discussion. So we just consolidated that into about 10 minutes, and I was hemming and hawing for about 2 days on whether we really should be getting the biopsy. Hematology absolutely wanted it. They said that if we see TMA on the biopsy, we're going to start eculizumab. And I tried to convince them that it was non-specific. So I went back and forth. And ultimately I had, the diagnosis of ATN or this classic HUS. And that was kind of my differential. And even though those weren't really going to change management, I felt that this is a young woman who may be on dialysis forever. And I don't know, I wanted to know, and I wanted to know if it's the case, if it's going to recur to transplant. So I kind of just wanted to document that it's TMA versus ATN, and that may not be that great of a reason for a biopsy, but that's what we did.
But I mean, look, we've had people that wouldn't biopsy and probably wouldn't treat. We've had people that would automatically give eculizumab without a biopsy, and then we've got something in the middle, biopsy to maybe justify eculizumab, at least by hematology. So, I mean, that's the whole point of the controversy to me, and I think that's why this is such a good discussion. And I don't know if there's an answer. I don't think there is a right answer, and there often isn't in this conference. But what it is all about is discussing the possibilities and learning from the differential diagnosis and the reasons behind these various thoughts. I like all approaches. I have
So
no
here's
idea
the
what Steve.
Here's the first. Somebody who sits in on the biopsy conference was in our office, and they couldn't wait to walk into Roger's office and actually see the physical wheel. It's almost like the wheel has its own fame.
Has its own Zoom account.
All right. Well, Saba predict because the wheel's been very Saba.
Well,
No,
Neelam and Hamoud are not here.
Oh,
so.
Neelam's not here either. I know Hamoud's not here. Okay. Well, I'll keep spinning it. If it's not, then Dr. Gashi's going to read it. Dr. Corbett. Couldn't be better.
The wheel has spoken.
Yes.
You sure it wasn't Saba? It was Corbett? Okay.
Hey, I'm willing to hand it over anytime you want.
The wheel loves Saba, but she predicted it was going to be her. But it's just to prove that the wheel is not rigged. It was Dr. Corbett today.
When the second years are away,
Which is it's very fitting because he wanted the biopsy.
Yep. Go ahead. Click on the screens, Steve, and you'll be able to. Yep. You can control. Yep.
Got it. It doesn't seem to be moving. There we go. Did I go too far? Yeah, I guess I did.
Yep, there, right there. This is the first one. Yep.
So we have a trichrome. Was this an IR biopsy? Because it looks like a very thin core. So it looks like IR uses 18 or 20 gauge needles, and you can see a fairly thin core. It looks like this is mostly medulla. David, are you on?
Yeah, I'm here.
Okay, here's a glom here. This is a blood vessel, it looks like. This I believe is medulla. Up here, I think we've got some cortex, but I only see, and I know this is a very low power, I only see one glom. It's, looking up here, assuming maybe this is the second one, this is the cortex. I'm going to 50% plus scarring.
Yeah, or maybe just edema.
Edema, okay.
Yeah.
I just see a lot of blue staining material.
Yeah.
It's hard to see. I don't see much in the way of the tubules, but let's go to the next. I don't know if
there's a little bit of a lag. There you go. Yep. You're on the right screen.
Okay. So here we've got I think it's an H&E, right?
Yeah.
So it's either red cells or thrombi, and I'm assuming these are all thrombi.
Yeah, but both, yeah, it's both. The pink are thrombi, the red are the.
Yeah, the red cells are the
Are
more
red
red
cells.
as the red cells, but there are a lot of, I mean, here you can see them really well. Well, thrombi within the capillary lumens here. Here's some red cells, but throughout. The mesangium doesn't look all that expanded, and the cellularity doesn't look that bad. Looks like there's a lot of, I know you'll have a PAS, but even at this power, it looks like you've got significant ATN with granular or at least casts within. I don't know,
The
David.
epithelium's completely necrotic.
Yeah. Up in here as well. I don't know if this is bleeding. These are red cells within the interstitium. Up at the
Yeah,
top.
it's off the screen. I can't quite tell.
Oh, all right. Let's go to the next one. This is a very high power of what looks like, I'm assuming this is one glomerulus. Here's Bowman's capsule here. And here's some red cells, but these are thrombi within the capillary lumens.
Yep.
Is this a thrombus too?
So that's the tubule there. You just
That's
can't
a
see the
tube,
lumen.
but this is glomerulus over in
Yeah.
here.
Yeah.
All right, so the tubule must be compressing on, because I can see Bowman's capsule coming around here, and I don't know if it's up in here as well, but for sure you see a large thrombus here.
Yeah. And then also you could see at the bottom left some schistocytes, fragments of red cells.
I don't know if you're looking at these things here.
Yeah.
These okay.
Steve, in that area around 10, 11 o'clock, do you think there is mesangiolitis there? I don't know if David agrees or not.
I mean, right here, these are all red. I don't know. I mean, up in here.
Yeah, if you go, and up and to the right of it. Yeah, keep going up. Yeah, right there. Yeah.
Right in here.
Where you were to the left a little bit.
Right here.
Yeah.
Okay,
Yeah,
this area.
Mesangiolitis there.
Okay.
Yeah.
All right, good call, Mario.
Yeah, good call.
David, what's the significance of mesangiolitis?
It's not specific for a disease entity. You could see it in different things. TMA is one of them.
I mean, is it due to ischemia, or what is it a result of?
I don't recall the exact pathogenesis of it.
Okay.
I was taught, for whatever it's worth, is that it's a manifestation of glomerular ischemia, and it's quite often seen in TMA.
Yeah.
Snake bites, venom. I remember that on the list.
And that makes sense because that would be cortical necrosis and severe glomerular ischemia. So,
Yeah.
Doesn't this look more like patchy or even complete or near complete cortical necrosis?
Yeah. Well, I mean, what we saw initially for sure, because the left up, on the trichrome, the left portion of the biopsy was with cortex, and what David said was edematous. But I mean, now we look at this, and I assume this is all cortex. Here's one glom with all these thrombi and red cells, but this looks completely decimated.
Yeah. So this is an area of acute renal infarction. It's all coagulative necrosis.
Yeah, and infarct and wow.
Hence the anuria. There's nothing more I have to comment on in this, so we'll go to the next.
Yeah, and so
There's a higher power of that
power,
same
yeah.
glomerulus, it looks like.
Yeah.
And again, you're saying these are red cells as opposed to they're thrombi for sure.
Yeah.
But I assume this glom is on its way out.
Yeah, again, yeah. So this is an area of infarct. You see, there's no viable cells here. It's you see the ghostly outline of structures, but it's
No nuclei hardly at all.
Yeah.
And then out here again, more like it's infarction or ATN.
Yeah.
I mean, none of the tubules look viable. Here's a blood vessel, which looks
healthy actually.
It's intact. Yeah, I was just gonna say it's the one viable thing on the particular view.
I want to stress how important it is to distinguish ATN from necrosis of the of the cortex. ATN being generally, I mean, of course, my panel knows this, but it's really important because we've talked about cortical necrosis here, and there's some evidence of some dead kidney tissue, which is very different than ATN, which for the most part will completely regenerate for the most part. So, and that was brought up all along, will there be cortical necrosis? And this patient is anuric. So I think it's a hugely important finding.
Which involves not just the interstitium and tubules, but the glomeruli, I guess, probably most importantly, right? that are ischemic and no longer functioning. I mean, here's a silver stain. I mean, some of these, these capillary lumens appear dilated, almost aneurysmal to me. And again, it looks like there's thrombi as well as red cells. Here's more thrombus. These are, I assume, some red cells. Some will coexist. Here's another thrombus. I mean, but just this entire thing is completely abnormal.
Yep.
Hey, David, sometimes with ischemic glomeruli, we'll see, retraction of the whole tuft and then what appears to be an expanded Bowman space. Is that because it's the preglomerular arterioles that are affected? And possibly if the glomerular arterioles are affected, it won't shrink down? Maybe before there's ischemia and causes it to shrink down? Is that the difference here? Because we're really not seeing that here.
Yeah, and I think this is an acute process. I mean, it looks like this happened just within hours or days at most.
Yeah.
Yeah.
No, but the thrombi I think Bill's alluding to are actually intraglomerular as
Yeah.
opposed to like the afferent arterial or something.
Yeah, I think that's a good point. Yeah, I agree with that.
I don't see anything else here. I mean, I don't see spikes or holes to assume that there might be some coexisting problem. Like, an autoimmune, like membranous, if you will. I mean, proteinuria wasn't a big issue with her anyway.
And did you see non-glomerular arterioles with thrombi also, David?
No, the thrombi were all in the glomeruli.
Okay, interesting.
So IgA, IgM, IgG appears to be all negative. I'm assuming, no, God, I'll go to the next.
The entire immunofluorescence was negative.
Okay,
except for fibrin.
I was just going to say, I'm saying this, and all of a sudden I figure I'll click on something and it'll be lambda light chains only or some crazy thing. But we'll assume it was all negative. And here's fibrin. Interestingly, I mean,
Look up.
Looks like it's in the capillary walls almost.
Yeah. But at 12 o'clock, you got a good intraluminal thrombus.
Right in here?
Yeah.
Okay. Yeah. I mean, most of this looks like it's in the capillary walls for the most. So EM's not enough tissue. I don't know that would have added anything between the fluorescence and the light. So diagnosis. Oh, sorry.
I'll take over here.
I'm going to stay. I'm staying away from the clicker. It's not my thrombotic microangiopathy. And given what we know so far, I assume we'll get some test results back, but this goes along with, HUS, given at least the history that we have. But what we can say is there's a thrombotic microangiopathy that's causing this patient to have acute renal failure. And then more importantly, as Roger was alluding to, and she's got renal cortical necrosis, which portends a pretty bad prognosis.
Yeah, cortical necrosis and anuria. Yeah, I would think so, but I don't know. I don't know how predictive that is, but it does concern me.
Well, once the glomeruli are gone, I don't know that they recover, as you alluded to, like the tubules might.
Yeah.
Dr. Radby, I have a question for the pathologist. If you see platelets in the thrombus or fibrin in the thrombus, does it give away the etiology? Either it is TTP or it is HUS?
No, I mean, the TMA is an umbrella term with many different causes, and histologically they all look similar, so it requires clinical correlation.
Okay.
It's our three favorite words: pattern of injury.
Thank you.
Roger, turning back to the original discussion pre-biopsy, what did this finding contribute to in terms of management of the patient?
Well, let's ask people. Let's go to the next poll. And this is real time. At this point, we have the biopsy. We still don't have an Adams TS13. The stool toxin assay is still pending. What would you do now? Did this help you or did this not help you? And what would you do now? Would you plex the patient? Would you give eculizumab? Would you do some complement studies, or would you just do conservative care? Answers are coming in, a few more. We could stop it there.
Looks like a coin toss.
It is pretty equal. Yeah, we've got, yeah, pretty much equal along all four lines. Um,
Yep, pretty equal. Completely equal, really.
yeah, yeah. Casey, what would you do?
I would definitely send off, I mean, the part of this case that still puzzling a little bit to me is the fact that if we think that this HU, a diarrheal HUS occurred because of what she ate at the hospital, and there are no other cases, is there something about her that's different because other people didn't get it? And so is there one of those predisposition type of mutations that she may have that could be present in her, and this was kind of that second hit? So I actually would do complement and genetic studies in her. I am not too familiar with the data on inclusivab in diarrheal HUS. The plasmapheresis, the data for doing plasmapheresis in Shiga toxin-induced HUS, from the American Society for Apheresis is grade 3 and 4, which basically means the data is pretty iffy. So in general with TMAs, it kind of depends on what you're removing. And in this particular case, I wouldn't do that either. So I would just send off genetic studies. She's already on dialysis. The question of inclusivab, I don't know if the data is that robust.
Dr. Glassick, you brought up the question. Did it help you at all?
Not much.
Would you call this?
I don't think there's anything in the biopsy that you could point to and says, gee, this requires a specific treatment. I think she is either going to recover from cortical necrosis or not. And frankly, I don't think there's anything you can do to determine which is going to favor one over the other.
Now, Adams TS13.
I don't disagree with doing complement genetic studies. You'll get them back in 2 to 3 weeks, maybe if you're lucky. And
if you're lucky.
If there is something, it may be far too late to use inclusivab. So I think the inclusivab discussion is going to have to be based on what data you have available today.
Is anybody still worried about TTP? We're still waiting for the Adams TS13. Is anybody still worried about that they would empirically treat until that came back? Mario?
No, and somebody brought up the plasmic score, and actually, although it's not 100%, it's helpful. Basically, for those in the audience that are not aware of it, it's a collection of factors such as platelet count, reticulocyte count, haptoglobin, blah, blah, blah. And if it is over a certain percentage, of which I don't remember, you can begin pheresis pending the Adams 13. In this case, eyeballing it is going to be low. So I wouldn't worry about it. And much like Casey, I also think that I would send complement studies and begin eculizumab. One note is that in Argentina, there were epidemics of HUS in kids, 20, 30 years back, and they were treated with PD. And interestingly, a significant number of them did improve. So the door should not be shut on the basis of the biopsy. Remember, the biopsy is a small sample here and not overall representative of what may be going on in the rest of the parenchyma. The actual appearance that Dr. Glaser referred to takes months to develop, so it's not going to be helpful.
So I got to give Dr. Baxi credit. I think he's outdone himself with pulling up the plasmic score online that quickly and filling it in. I'm very impressed, Pravir. And I'm glad you brought that up because I saw it in the text and I really didn't know enough about it to comment on it. So I'm glad you brought it up and I'm glad you showed us it's readily available and it kind of gives you somewhat of a guideline. The problem with these scores, of course, is that it might give you a 90% answer, but sometimes you can't afford to be wrong. I don't think it's strong likely in here based on the presentation, but sometimes you can't be afford to be wrong, and it doesn't matter what your score is. You have to treat accordingly or empirically. So Mario, you would also give eculizumab?
Yes.
Good. So we've got really quite interesting varying opinions here on that. I like Dr. Gashji's point about complement studies. I hadn't really taken it seriously, but Dick brought it up early in the case that no one else seemed to get sick, and that you'd think that this was a restaurant that more than one person would get sick. And I think it's, who knows? Maybe it was a little bit of toxin and had a genetic predisposition with my favorite two-hit theory. So I like that idea. It's not going to change anything acutely, but it may impact how you think about it in the long term. I'm going to hand it over to Bill.
Isn't there transplant implications with the various mutations in, at least in atypical HUS? I mean, some of those mutations, like, complement factor H and I, your chance of recurrence in the allograft is quite high, like almost, 100% you can have recurrence, whereas, membrane cofactor protein, some of those other mutations, the recurrence rate is pretty low. So at least from a prognostic standpoint, I'm not saying this is atypical HUS. Obviously, you have diarrheal induced HUS here, but again, the whole story just doesn't seem like she's the sole person that ate this and this happened to her. So maybe there is something there.
No, I think that's a really good point. On the other hand, there's a lot of people that have found to have these complement abnormalities, and they do fine their whole life till they get pregnant or some other second hit, and maybe they wouldn't. It's not like having without an obvious second hit. But I still think it's an excellent point. For sake of time, let's hand it over to Bill.
Thanks. Yeah. So
I'll give you control here. Give me a second here.
yeah, what a great discussion, though. Thanks, because this is really what was going through my mind. I wasn't that convinced to do a biopsy. I didn't really think it would change our management. It clearly hasn't. What we really need here is the ADAM-TS. We need the Shiga toxin. We need the complement studies, and all of those are blood tests. But I think we decided to do it anyway. And I think, knowing was informative, but it may not have changed our management. In this case, let's see here. Sorry. Here's how she did. We did the renal biopsy, right around there. And this is, again, this is her information. And so this was just a month ago. And she was anuric and she required dialysis, and she transitioned to outpatient HD, still on dialysis and still anuric. Hematology also wanted to give eculizumab. By the time we got some of the other tests back, our ADAM-TS13 activity was normal. It was 62%, and the reference, of course, is positive if it's less than 10. So it should be normal greater than 10. And her antiphospholipid antibody panel, as well as her anti-scleroderma antibody panel, was also negative. We finally got the Shiga toxin back from Mayo Clinic, and even though her stool culture was negative and all the other stool studies that we had were negative, her Shiga toxin ended up coming back positive, and it was for the E. coli. They were able to trace it to the OH1757. And around that same time that came back, we had her atypical hemolytic uremic syndrome complement, as well as antibody screens, and everything was completely normal. There was no even heterozygous mutations. It was just completely normal or negative. So what we have here is a case of pure Shiga toxin induced HUS, ST-HUS. And in the hospital, she was maintained on hemodialysis. She actually had some episodes of vertigo and also a couple episodes of blurry vision. And there's known CNS toxicity with this, so that was kind of concerning. But that also resolved with time as far as her symptoms of CNS issues. And so in TMA, just like we discussed, there's all these wonderful causes. It's completely a pattern of injury. We've been able to narrow that down with science over the years. I think it's really been a cool story, the TTP story, finding out that plasmapheresis worked, and then finally we were able to, find out that it was due to ADAM-TS13 deficiency, Shiga toxin and the diarrhea positive here. And we don't really even call it atypical HUS anymore. It's more of a complement associated HUS. But here's all the different causes, and it's really hard in real time to figure out which one it is. I mean, this was a pretty obvious one, right? It was bloody diarrhea, and it was still hard to figure out. So I think that's, sometimes they'll come in with malignant hypertension, right? And are they hypertensive because they're in renal failure and you don't have a bloody diarrhea story? And so even those ones are hard to figure out. So it's not always as easy, but this was about as clear of a case clinically as I thought we could have. And so thus hematology actually after the biopsy was really raring to give eculizumab. And I thought the clinical story was good enough that we weren't going to need it. And so we elected to not give her eculizumab. When you have it, here's your standard workup, but we kind of talked about this already. We got to make sure that we get the ADAMTS13 activity back, and then we're into that non-TTP type of TMA that we discussed. So when you found out that it's Shiga toxin producing, it's actually not just E. coli, but also Shigella can do it. And the classic New England Journal article showed that when you give antibiotics, actually it increases the release of Shiga toxin and can increase the TMA type symptoms. There's a lot of controversy on that, on whether you should give antibiotics or not. The infectious disease literature has some suggestions that if it's due to Shigella, you actually need antibiotics, but if it's due to E. coli, then you don't. So it's very confusing to me. And we had infectious disease come on this case because I originally said stop the azithromycin and don't give any more antibiotics. And infectious disease, until we had the Shiga toxin, came back and said, no, we do need to give some antibiotics. And so I deferred to them and allowed them to obviously do that. So, oh yeah, Casey, I see that in the chat. I'm going to talk about that in a second here. In TTP, classically, we have too many of the unusually large multimers of the von Willebrand's factor that are allowed to persist in the serum because you don't have the cleaving protease. The metalloprotease isn't cleaving them. And then you're left with this platelet, not only adhesion, but then platelet aggregation. And in Shiga toxin, the actual toxin binds to that GB3 receptor that's located on the endothelial surfaces, and it's mostly in the brain, gut, and the kidney. And they found that in the kidney to be in the mesangial cells, in the podocytes, also in some of the proximal tubular cells. And after that binds, it actually releases more of the von Willebrand's factors into the circulation, and that's how you get your platelet adhesion and platelet aggregation. So it's not from a lack of metalloprotease, but it's for an increase in the unusually large multimers from that binding. And so thus, you wouldn't really expect that plasmapheresis would work. Plasmapheresis, of course, is going to give the metalloprotease back, and it's also going to remove the antibody that's directed against the ADAMTS. And so typically, plasmapheresis is not useful in the setting of ET-HUS or enteric toxin HUS. Therapy right now is only supportive, but is there data for eculizumab? And I think Dr. Reen commented that there was some, and also Casey had just put in the chat that the outbreak in Germany, it was actually with sprouts, it was the other E. coli. It was the 0104 or something, 0104. And they used eculizumab after plasmapheresis in some of those patients. And based on that, eculizumab was approved by the FDA in the United States for treatment of atypical HUS, not Shiga toxin, but it was almost based on the Shiga toxin outbreak. But when they went back, Casey, at those studies and they looked at them, there was actually no difference in the patients that got eculizumab versus not. So it wasn't even helpful in that situation. There's a couple scattered reports of it being successful, but there's been nothing that's controlled that has been able to show that eculizumab has successfully improved outcomes in Shiga toxin HUS.
However, we don't know if it's ever been powered to actually
Correct.
study that specifically. They're just,
Like
everything's a case report here and there in retrospective.
3 patients here or there, 4 patients here or there, nothing controlled.
I just want to comment on Dr. Bashti's point. What I was saying at that time, that there are soft data in eculizumab in pediatric population with typical HUS. I wasn't implying that there is a solid data on that. But what I was saying at that time, I knew the plasma score was not very high, so I can get away without plasma freezing this patient. But I wouldn't have gone wrong if I have used eculizumab to start with without biopsy. That's the point I was trying to make. And plasmic score, I understand, is also a KDIGO recommendation that we should calculate. Like we don't have plasmapheresis in our institution, so it's a good tool. We use it when we're transferring people out to the plasma exchange center, that we can tell them plasmid score is a high at 6 or something, then you can refer them quite easily. So it's a useful test, and it is a recommended in KDIGO guideline, if I remember correctly.
Dr. Reen, after the biopsy, and even after the, after the biopsy, would you have then not?
No, I
Given
wouldn't
more-
give a cruzamab then.
Okay, you were doing it empirically before.
Yes, I was doing, because she is very young, and I don't think I was doing any harm in giving cruzamab. That's the way I think
Yeah.
it.
And Dr. Rubin, how strongly do you feel about it?
Well, it's interesting. We begin to say many diseases complement has no role, and so far in Shiga toxin HUS has no role. So why use eculizumab? But I think that the jury is still out. As you pointed out, we'll see what additional trials tell us when properly done. I stick to my guns on. I would have used eculizumab, and when the Shiga toxin came back negative, forget it. I would have stopped it.
You would have stopped it, okay.
I'm puzzled by two things that Bill, one of them Bill commented upon. What is the theory behind why? I didn't know this. Antibiotics, when used, may worsen Shiga toxin HUS. And number two, what made this poor lady the chosen one? I mean, do we know certain HLA types or risk factors that make a person more susceptible to Shiga toxin HUS?
Well, I certainly think that that's why we were so, that's why I still wanted the panel sent off, because I thought she may be a heterozygote, or she might have something like that. And if that's the case, maybe I actually should have used empiric eculizumab until that came back. When public health got involved, they actually traced it to a bite, a steak that she had, and it wasn't from the hospital cafeteria. And the bite of steak that she had was one bite of her boyfriend's steak, and the boyfriend had the whole steak, and he didn't get sick at all. And she had one bite. And so it was really, why her? Why her? And believe me, she's asking me that. And so I'm not sure what her risk factors are. Is it possible that Raynaud's is making her at risk, or something like that? So we checked everything that I can think of as far as the antiphospholipid antibodies and scleroderma and all that kind of stuff, and everything that we knew came back negative. I don't know though about HLA. And I don't know that in the literature, so it's a good question, and I can get back to you on that.
She didn't go to McDonald's or Burger King, did she, by chance, and just didn't tell us?
No steaks there.
She did go to Wendy's, and she had a chicken sandwich there, but the public health thought that wasn't due to that.
Bill, you didn't ask her about
Bill, or
Go ahead.
Sorry, one more time.
Roger?
What about the antibiotic story that they worsened Shiga toxin HUS?
Sorry, you did mention that. Yeah, and that's based on this New England Journal study, and I think it was 1998, but I should have, it was over 20 years ago, which showed that there was, in the group that got antibiotics, there was more thrombotic complications, and so more TMA. And so the thought is that as you're killing the bacteria, it's releasing more of the Shiga toxin into the circulation, and then there's more that can bind. And that's the theory behind why antibiotics are not supposed to be given in your classic E. coli 1. However, there's a lot of controversy there. It's not as clear as one article makes it seem.
What happened to her?
Roger?
No, we're fine. We're fine. We're going. Keep going.
Well, earlier I heard someone comment that the imaging findings of renal cortical necrosis are so delayed that they don't have any clinical utility. I would agree that that's true for the so-called shell of calcification. That takes weeks or months to occur, but there are immediate imaging findings that are pathognomonic of renal cortical necrosis, the so-called reverse cortical medullary junction finding on CT findings, in which you have no perfusion at all in the cortex and hyperperfusion of the medulla. Exactly the, it's the opposite of ATN. So I think there are imaging procedures that can increase the diagnostic probability of cortical necrosis if it's total. Now, if it's patchy, you know, it's anybody's guess. And
What
I guess
is the name
the
of
people
that
who were happy with the biopsy here is that it demonstrated a disease that cannot be treated. And therefore it avoided the use of drugs like
study?
eculizumab or plasma exchange. My argument is that you may have achieved the same degree of certainty with regard to lack of effective therapy by doing appropriate imaging studies early, within hours of the diagnosis of anuric HUS following bloody diarrhea.
Dick, what is the name of that study? How do you order that particular CT?
Well, it's a standard CT. You give a little bit, you don't give a lot of contrast, just enough to outline the outer cortex in normal individuals. And in this case, when you do a CT, the cortex is absolutely lucent. It has no contrast at all. So it's a rim of non-perfused cortex with a hyper-perfused early contrast accumulation in the medulla. It's called the reverse cortical medullary junction sign. Look it up
It's
in,
like
it's called the reverse cortical medullary junction sign of bilateral total cortical necrosis, and it appears early, within hours.
So
yeah, that
very
reminds
interesting.
me of the whole xenon washout in HRS.
Well, I mean, the case was made that I want to do a biopsy to know what's going on. And I don't argue with that. I think it's okay. But in this case, the biopsy findings didn't help you at all in terms of what to do with the patient, because it indicated that all you need to do is monitor and wait, see what happens, which is
So
what Bill did, right?
That's right.
Bill,
Yeah,
you
we did
didn't-
not give
you didn't-
eculizumab. The real helpful part of this case was getting the complement studies, the shigatoxin and the ADAM-TS13 back.
So before we, Mario asked what happened. I want to poll my few of the audience here, just a kind of a yes or no kind of answer. This patient's been anuric. She's on dialysis almost 3 weeks. Mario, did she get better?
Did she get better? I don't know. I mean,
No, you got to say, I
think-
want an answer, yes or no.
Oh, I want an answer. Well, you know, I never forget what Tom Starzl told me once. And that is, Mario, I have seen cases of acute anuric renal failure getting better even 6 months into dialysis. So I think it's early. I'll keep it up and hope for the best.
So you're saying yes.
Yes.
Dick, did she get better?
Yes.
Dr. Reen? No, we got a poll. Dr. Reen, what do you think? You're muted.
I will definitely give her a chance to watch for recovery in this patient.
That's
even
not
if
the
it
question,
is-
Dr. Reen. That's
Yes,
not the question.
yes,
Okay.
yes.
Dr. Gashty, did she open up?
Remember, it's September 21st, and she left the hospital on August 25th.
I don't think so. I don't know. I feel like it's shed a lot of thrombi and those capillaries were all plugged up.
All right. So our poll has 2/3 of the people saying she got better, but 1/3 said no. And I think, Mario's point's really good from Dr. Starzl. I think, you can't always predict, but boy, I'll tell you, cortical necrosis and some pretty bad thrombi and anuria, I'm not so sure I'd feel that way. So Bill, tell us.
We did talk a little bit about the eculizumab, and just to you're classically going to want to give this, of course, an actual complement mediated HUS, unless you're going to enroll those patients in clinical trials, which you should always think about as well. But we really want to give it sort of empirically when you don't have another clinical diagnosis. And so, the first thing this from up to date is you're going to want to think about this when you have TMA with AKI in which there's no bloody diarrhea, TMA and AKI which you don't have the history of the drug-induced TMAs like quinine and so on. So I think in this case, I decided to hold off on eculizumab just because we had a very good clinical scenario. where it'd be given. And as she transitioned to our outpatient dialysis unit, she started making a little bit of urine, and then she started making quite a bit more urine. And she, about 10 days after she left the hospital, was able to completely come off dialysis. Her creatinine is now 1.1. Her hemoglobin is back up to 11.2. She once again is on no medicines, and she's telling me that she's going to become a vegetarian.
That's probably a wise choice. Well, that's really a great case. I think that it can be very simple, as Dr. Glassick has kind of presented. This is obviously atypical, or rather typical HUS, Shiga toxin related. You don't do anything, you watch. But I don't think without this, we had a great discussion, because I don't think it's that easy. Maybe his wisdom, or maybe he got lucky, or it doesn't really matter to me. I learned a lot from this case, and I think our audience did, and I think it was a great discussion, and I appreciate everybody's input. So thank you very much. I did not welcome, we have some interviewees today. I want to welcome, it is fellowship interview time. I want to welcome them. We'll be talking to them shortly. We will be back next week, I believe. Keep an eye open. I want to wish everybody a happy Rosh Hashanah this weekend, and we'll see you next week.